Hi, I am so elated to meet you in the program of JIP's Horse and Heart News. 2 weeks before, we received a patient, 65 years old male, presenting with severe left-sided chest pain, turned out to be a case of pneumonia. So please remember that those who have pneumonia can present with cough and breathing difficulty and sometimes productive sputum. But please remember that most of the pneumonia patient, they will have pleuritic involvement and they will have pleuritic chest pain as well. When they present with pleuritic chest pain on the left side, it may get confused with acute coronary syndrome. This patient also, before he got admitted, he had chest pain and mild fever. Of course, fever was absolutely ignored by patient relatives. So for chest pain, he was evaluated with echo and ECGs multiple times in a span of 4 days, but turned out to be negative. Then when they presented to us, then chest X-ray revealed multiple heterogeneous opacities and suggestive of probable atypical pneumonia. So when you approach pneumonia, there are two types of pneumonia. One is community acquired pneumonia and second one hospital acquired pneumonia. When somebody presents with pneumonia, then you have to classify whether you are dealing with community acquired pneumonia or hospital acquired pneumonia. So what do you mean by community acquired pneumonia? So development of pneumonia in those who come from community itself directly, or they develop pneumonia in the hospital within 48 hours. What is hospital acquired pneumonia? It is development of pneumonia in those who have been admitted in hospital and they develop pneumonia after 40 to 72 hours. Why you have to classify whether this pneumonia occurred from community or this pneumonia occurred from the hospital? Because the organisms responsible for community acquired pneumonia and hospital acquired pneumonia are extremely different. So they warrant different types of antibiotics. So for example, community acquired pneumonia, the most important organism would be Streptococcus pneumonia and H. influenza. On the other hand, hospital acquired pneumonia, you have Klebsiella and Pseudomonas and E. coli and so on. So you have to choose different spectrum of antibiotic based upon the pneumonia. So in our patient, we suspect strongly atypical pneumonia. So what are the classical pictures of atypical pneumonia? So why it is called atypical? So basically atypical pneumonia is caused by organisms of Mycoplasma and Legionella and Chlamydia and so on. Why they are called atypical, or why their pneumonia is called atypical pneumonia? The first most important, these atypical organisms lack cell wall. So how it is clinically relevant? Yes, it is very much clinically relevant in the sense, since it lacks cell wall, the antibiotic which act on the cell walls of bacteria won't be useful against these bacteria. Generally, we use beta-lactam antibiotics which target cell wall of the organism. Since atypical organisms don't have cell wall, these beta-lactam antibiotic can't act on these organisms anymore. So beta-lactam antibiotics won't be useful when you suspect atypical pneumonia. That's why we prefer either macrolide or doxycycline. And second one, these atypical organisms that produce pneumonia exhibit different type of manifestation. For example, if you take a typical bacterial pneumonia, they will have prominent high-grade fever and chills and rigor and severe cough and breathing difficulty. Here in atypical pneumonia, more than the pulmonary symptoms, they have pronounced extrapulmonary symptoms. For example, if you take Legionella pneumonia, they will present with diarrhea and vomiting like GI symptoms. When it is associated with hyponatremia, which is a common phenomenon, even they may present with drowsiness and altered mental status and so on. Likewise, if you take chlamydia or mycoplasma, for example mycoplasma pneumonia, they may present with otitis media and even Stevens-Johnson syndrome, and they will have features of hemolytic anemia. So they may present with different extrapulmonary symptoms. That's why we used to call atypical. And moreover, it is very difficult to isolate them on routine staining, on routine culture. That's why we used to say these are atypical organisms. Though this patient also was suspected to have atypical organism, so we instituted Acithro as an injection. Patient recovered quickly. So within 72 hours, patient got discharged. Thank you.